Hi, I'm Jonah Comstock, editor-in-chief of pharmaphorum. I'm here in ASCO in Chicago. It's day 3, and I'm joined by Dr. Jess Paulus, the Vice President of Real-World Research at Ontada.
Thank you so much for inviting me.
So, yeah, thank you for making the time to chat with me. I was really interested to take a look at your abstract because it deals with sort of the intersection between GLP-1s and cancer. And I think that's a topic that's really a little bit understudied right now. So tell me about the paper and what your findings were.
Yeah, so I think there's a lot of interest in the intersection between metabolism and oncology, or particularly cancer and metabolism. And so the backdrop for this work is that, this is one of the fastest growing drug classes in history. There's estimates that 1 in 8 Americans are on a GLP-1 right now. We're also more recently seeing some intriguing evidence that there could be an anti-cancer effect of GLP-1s, in addition to the very well-known metabolic benefits associated with use, the real indications for diabetes, chronic weight management, cardiovascular risk reduction. So essentially, there have been a couple studies out there suggesting a potential anti-cancer effect in human populations, but none to date that were sort of large scale, leveraging real world data, and that were done across multiple tumor types. So that was the gap that my team sought to fill.
And that's fascinating, right? Because you can sort of connect the dots to cardiovascular, some of these other areas where you're saying we're starting to see benefits. But what's the mechanism that allows these drugs to have an effect in cancer? Or do we not know yet?
Yeah, we don't know yet, but we know that these drugs reduce inflammation, which is obviously a driver of cancer. We know that these drugs are associated with improved glycemic control. And like all cells in our body, cancer cells need energy to grow and to thrive, which is also unfortunate the cancer process. There's also there's some evidence suggesting that GLP-1s may have an anti-proliferative effect on cells. So the short answer is that we don't yet know, but there's multiple different potential pathways, including an intriguing one that I talked about yesterday with some oncologists about the reduction in the amount of adipose tissues. So that's not even necessarily a direct effect of the drug on cancer, but more it could be allowing chemotherapy or other cancer treatments to work better through a mechanism of producing adipose tissue.
That makes sense. And it also kind of points to the next thing I was going to ask about, which is real world studies, very, very powerful, but very tricky. Obviously, people like controlled studies because it's very easy to isolate the effect and design it out. So what were some of the steps you took to sort of make this study work and make sure that the findings are really robust?
Yeah, so in my humble opinion, this is the perfect place for real world data to make an impact. We're in the phase of hypothesis generation, and hypothesis testing, but not necessarily doing the definitive causal study. The two main biases that we had to contend with are confounding bias. So are GLP-1 users systematically different than non-users? Are they younger at an earlier stage of disease? Are there other things about them that are the reason they might be surviving longer that has nothing to do with drugs? The second main bias is the very difficult task of really accurately capturing GLP-1 use, because we made use of oncology EHR data, which is fantastic for studying cancer outcomes and the cancer patient's experience. But most GLP-1s are prescribed in not an oncology setting, in a primary care setting.
Or even outside of the traditional healthcare system entirely.
Absolutely, like direct-to-consumer stuff, telehealth, and all of that is a Wild West frontier. This is not even necessarily captured in claims data when patients are self-paying. So being able to accurately measure the GLP-1 use is extremely challenging. For confounding, we used kind of state-of-the-science techniques, propensity score methods, we've used regular multivariable modeling to adjust for the confounding. We did see evidence of some negative confounding, meaning like a healthy user effect, so that the GLP-1 users tended to be at an earlier stage of disease, and they were about 5 years younger on average. So we, of course, needed to correct for that in our analysis. We did correct for that through the propensity score. There is, however, always the potential for residual and unmeasured impact.
Sure. I mean, late stage cancer patients who've been going through a lot of treatment maybe are not worried about their weight.
Yeah, no, I think we didn't, we took all comers in this analysis. So it was 6 solid tumor types, regardless of stage. And I think we didn't do stratifications based on early stage or late stage, just based on sample size. But that's a really important next step because I think most clinicians would agree that weight management or use of these drugs is not a priority for patients who are struggling with the burden of their disease.
So what can you conclude from the work that you've done? What are the top takeaways from the study?
Yeah, so I mean, I think we saw a very clinically significant reduction in the rate of death, overall survival among patients taking GLP-1s. In other words, GLP-1s were associated with a favorable survival profile as compared to non-users. This isn't a consistent effect with other studies that have come out in the last 6 to 9 months. So many of us are asking this question with different data sets and different tumor types and coming to a pretty consistent answer. I'm not ready to say that this is causal, that this is the truth. I think what the next frontier of studies need to do is integrate additional data sources like claims, like maybe even data from some of the telehealth providers that are also capturing dosing and timing of use of GLP-1s very accurately because it's tied to payment. Integrating that with EHR data to kind of have the best of both worlds of great capture of GLP-1 as well as cancer outcomes. I think we also need to look at earlier stage outcomes, not just overall survival, but progression-free survival. We need to look at the interaction with cancer therapies. So to understand a little bit more about mechanism, if we do believe this, is there some interaction with the treatment that's happening here? So these are just some of the questions, but mostly I think we're about ready to, I think, motivate prospective studies. I think there's enough retrospective evidence that we need to take another step forward.
And as you discussed these findings in this space with other oncologists at this conference or the kind of ASCO attendees, what kind of responses are you hearing?
There's been a tremendous amount of interest. I think, because I think of the prevalence of use in the general population, I think there's a lot of conversations about these drugs happening in all kinds of medical specialties. People are starting to understand there may be, off-target protective effects. There's been links with reduction in the risk of dementia, Alzheimer's. There's actually a clinical trial that was set up to interrogate that question. So I think there's been a tremendous amount of buzz around this. And I'm in a lot of conversation with clinicians who are, I think, depending on the kinds of cancer patients they treat, really drives the kinds of conversations I'm having, right? So I think there are many clinicians who treat patients with a high burden of symptoms of their disease, for example, for whom this association or this potential finding maybe isn't of priority importance. On the other hand, we are really doing so well with the management of some tumor types with the advent of amazing new therapies that, managing chronic disease like obesity alongside cancer is actually an important question with the longevity of many patients extended, that being able to ask the question about optimal metabolic health is important as you're also managing their cancer burden. And then the question becomes, well, is this also benefiting their disease process with cancer? So tons of interest, but lots of questions that we have to tackle next.
That's fascinating. Thanks so much for speaking with me. Any final thoughts, anything we didn't cover that?
No. Thank you so much for the opportunity.
Thank you, Jess.